Okay, so this topic deals with diabetes mellitus, and diabetes is a condition which is very important for you guys as practitioners of optometry, because diabetes affects the eye, and you might be managing or co-managing some of these cases, and you might also be the first person to pick up on the fact that your patient might have diabetes. Okay. So diabetes is by definition, it's a chronic disorder of carbohydrate, fat, and protein metabolism. And in the complete form, it is characterized by elevated blood glucose following fasting, that is fasting hyperglycemia. It's characterized by glycosuria, or presence of glucose in the urine, and the tendency to develop different systemic complications like atherosclerosis and microangiopathy, which are all features of the blood vessels. We'll get into some of these. Nephropathy, where the kidney function is affected, and neuropathy. The nerves are affected, the nervous system is affected, both the central and the peripheral nervous system. And it's not a single disease, it's a group of metabolic disorders that manifest in the form of hyperglycemia, and it affects, regardless of the mechanism, long-term complications are present throughout the body, and most importantly in the kidney, the eyes, the nervous system, and the blood vessels. Okay. Normally, there is increased insulin secretion after a meal. So that is in response to the increased glucose in the blood after a meal. So following a meal that's rich in carbohydrates, you have increase in blood glucose, and the increase in blood glucose leads to increased release of insulin, which then tapers down over time as the insulin moves all the glucose into the cells. Okay? So in patients with diabetes mellitus, there is either an abnormal or no insulin response following increased glucose after a meal, and that results in hyperglycemia. So the graph out here, the blue actually shows how this is soon after a meal, the time after the meal, when it shows how the insulin levels in the blood change. Carbohydrate-rich meal, after that the insulin level peaks in the normal individual and insulin level drops after the insulin moves most of the glucose into the cells, whereas in the red shows the glucose response in a patient with diabetes after the same high glucose meal or carbohydrate meal, where the insulin levels do not go up, which means the insulin is not mobilized into the target tissues. The carbohydrate is not mobilized into the target tissues, so the blood glucose concentration is elevated. Diabetes is classified as primary and secondary diabetes. Primary diabetes, the problem has to do with either the production of insulin or the response of insulin at the level of the target tissues. Type 1 diabetes is usually an autoimmune condition. In this case, there is lack of insulin because the beta cells are secreting less insulin, and over time you have less and less of those beta cells. And if left untreated, the type 1 diabetes is fatal. The type 2 diabetes, here the insulin production is initially normal, but there is an increased resistance to insulin in the target tissue. And it is often correlated with, goes along with obesity. Gestational diabetes is a diabetes seen in pregnant women, and it is due to increased resistance to insulin by the target tissues, just like in type 2 diabetes. It's just that this is associated with pregnancy, gaining weight during pregnancy. And there are other primary reasons where probably the beta cells are not producing enough insulin, or there is insulin insensitivity of the target tissues due to genetic reasons. Okay. But here the primary defect is with insulin or the insulin receptors. Then diabetes is classified as, category is classified as secondary. They are secondary to other disorders in the body. Okay. We're not going to get into the details. The primary defect is not diabetes. The primary defect is something else that is leading on to diabetes. Those are the secondary diabetes.
Gestational diabetes after birth, are there any remaining complications that we should know about?
With losing weight, it can go back to normal, but usually there is some correlation between women developing gestational diabetes and probably developing type 2 diabetes later. They are at greater risk of developing type 2 diabetes. So I have a slide or two.
Professor, is the how much at risk is the baby?
I have a slide on that. We'll come to that. The baby is at risk. Okay. Not all babies, some are at risk. Well, the prevalence of diabetes is quite high, and these are actually some old numbers pulled out from some 5 years ago, like 6, 7 years ago. 21 million Americans at that time, which is much higher now. Type 1 usually develops in children, and more common in Caucasians. Type 1 diabetes was also, it used to be called juvenile onset diabetes, but we're not using the term as much anymore because it doesn't necessarily develop during childhood. We also have a lot of instances now where it manifests in adults. So we're moving away from using that term juvenile diabetes or juvenile onset and using more type 1 diabetes to indicate that the problem is the beta cells, the defect is in the beta cells. Type 2 diabetes, of course, it increases with age and obesity, and it's much higher prevalence, okay, and earlier ages, okay, in African Americans, Hispanics, and Native Americans. So the prevalence of type 2 diabetes is greater in African Americans, Hispanics, and Native Americans relative to Caucasians. And this map actually shows the diabetes prevalence that was estimated in 2007. The hotter colors you see are more in the South, the Midwest, and more so in the South. The darkest colored regions are out here in the South. And one state always raises red flag in all of these maps is Mississippi. This one actually shows, the top shows the prevalence of obesity, how it's changed from 94 till 2008. You can see how the colors have changed. We are an obese nation. And again, you see where that obesity is more. I mean, it's everywhere, all around, but it's more so in the South and in the Midwest. And this shows from the same study the prevalence of adults who had diagnosed diabetes. And again, you see where that is. It's more in the South and the Midwest. Okay. So it goes along with what the prevalence of obesity is, and it's increasing in every state. And this is from a more recent study, again shows the prevalence. This is not diabetes, but it shows the prevalence of obesity. And here, the hottest color is Mississippi. So Mississippi is the fattest state, and Colorado seems to be the leanest state. At least this was about 3 years ago. We are okay. New York is fine. Yeah, even in the previous maps, New York was not as bad as most of the Midwest, and in terms of both obesity and diabetes. But nevertheless, it's increasing in New York. And that's probably because of the increase in diabetes all around the country is because of the poor diet, eating more junk food, more fatty food, and less exercise, sedentary lifestyles. But of course, those maps don't differentiate between type 1 and type 2. And these are some more. I mean, just get the big picture out of it. There is more diabetes prevalence is greater in males compared to females, and more in the older age group, prevalence is greater, over 60 compared to less than 60. And again, this is showing the sex difference. Again, slightly more in males prevalent than in females. And this is broken down race-wise. If you compare all types of diabetes put together in African Americans, the prevalence is highest, and next in Hispanics, and then in Caucasians. Okay? And then a few other statistics, and I'm not going to quiz you on all this. Yep.
Would you posit that our generation would prove a decrease in diabetes due to the fact that
Increase?
decrease due to the fact that especially like when we were in high school, they did like a whole survey thing where they checked our weight and they increased the awareness. They also like they stopped the vending machines at like some.
We'll see. We'll see.
I
Yeah.
just I think it might.
These studies take time. We got to see. And our generation also, they didn't have video games in the older generations. The kids had to leave the house and go play outside. Even for various reasons, we don't let the kids out as much, so the kids are, there could be lots of, bottom line, we don't know. We got to wait and see.
Yeah, I just think it might change because of the increased awareness.
Maybe. Got to wait and see. Yes. Some other hand went up.
Yeah. For the graph that you just had up there, can you just explain the insured one? I didn't know if it was insured. Does that say that?
Which one?
I couldn't see it. The one that says insured.
The one at the end.
Yeah.
This?
Yeah. What is it? What are the numbers?
This is like 13.3 and 9.2, the prevalence of diabetes in insured patients with insurance and patients without health insurance. Okay, it's roughly the same. It's not very different. This has a lot of numbers, and I'm not going to quiz you on numbers. And again, you need to take some of these smaller effects with a grain of salt. Okay, so type 2 diabetes, the prevalence is increasing in children, okay, and that has been attributed to increase in childhood obesity in children, okay, and that is really increasing compared to before. It's more sedentary lifestyle and diet. And just comparing the increase in the number of overweight people in different countries, if you see. We are sitting right up here, okay? No matter which year, 1970 or 2000, 2003, the United States is way up there. Okay, there are different tests that are used to measure blood sugar, and these tests aid in the diagnosis of diabetes. So some of the tests, you would have probably heard about all of these tests at some time or the other. There is casual plasma glucose concentration. You just walk in, you're not dieting before the test or anything. So randomly you walk into an office or just get your blood sugar at home or at a lab tested. whenever the random blood glucose concentration is greater than 200 milligrams per deciliter, that raises red flags. Or if after fasting, if you measure blood glucose and it's greater than or equal to 126 milligrams per deciliter, which, of course, if you get this value the first time, there could be something odd, but then if on repeated measures, if you get the same level of fasting plasma glucose, then that's hyperglycemia, and that's a sign of diabetes. Then there is oral glucose tolerance test. So 200 milligrams per deciliter. So you administer a known amount of glucose, and 2 hours after the test, the known amount is 75 grams of glucose is consumed. It's more liquid. It's a nasty tasting fluid. And 2 hours after that, they actually test your blood glucose, and if it is greater than 200 milligrams per deciliter, then that's a sign that you may have diabetes. So there is this, so the 3 types of blood glucose measurements, okay? So the casual plasma glucose, the fasting plasma glucose, and oral glucose tolerance test, okay? And these numbers are important, okay? Because a lot of times when you're taking history in the clinic, your patient may not remember numbers. They might just pull all of this, say, I've had diabetes for 20 years, and they're going to pull all these papers and show it to you, and you need to know what is normal, what is abnormal. So I expect you to remember these numbers. And this is the oral glucose tolerance test. The red curve actually shows the glucose levels after consumption of that 75 milligrams of glucose. And normally, this is the profile, whereas the green shows in the case of a patient with non-insulin dependent diabetes mellitus. Okay. So here, the blood glucose stays up for a much longer period of time. So 2 hours after consumption of that glucose, it's way up here. Okay, so we have these numbers for who has probably likely has diabetes and does not, but then there is a normal range, there is a intermediate range where they talked about as being pre-diabetics. So they're at a higher risk of developing diabetes at those intermediate levels. So if you take the fasting plasma glucose, the 126 milligrams per deciliter or greater is a sign of diabetes. Between 100, 100, and 125, they're considered a pre-diabetic, and less than 100, they are usually considered normal. The pre-diabetic range is between 140 and 200 milligrams per deciliter for the oral glucose tolerance test. So anything greater than 200 is highly probable that they're diabetic. Less than 140, they are normal. Okay. And so that's what these arrows are showing, the same thing. So the pre-diabetics, if you're in the pre-diabetic diabetes range, then you have a significant risk of progression to actual diabetes. So that's 5 to 10% of the individuals in the pre-diabetic range actually proceed to being diagnosed with diabetes much later. Okay, another test which is used a lot these days is the hemoglobin A1C content measurement, HbA1c. HbA1c is the percentage of glycated hemoglobin. So the glucose combines with the hemoglobin, and this happens when the blood glucose concentration is very high. So they just sample the blood and measure the glycated hemoglobin content of the blood. Okay, and that correlates with elevated blood glucose. One advantage of doing this test is here this glycation, the binding of the glucose to the hemoglobin, is irreversible. Once it binds, it remains bound, and then the only time you get rid of it is when there is a turnover of the RBCs. The RBCs are constantly turned over, so you can have several weeks before those RBCs are destroyed and new RBCs are formed. So the HbA1c levels actually reflect the blood glucose over 2 to 3 weeks to up to 2 months. Okay, so they show over a period of time it is indicating that the blood glucose has been elevated. You don't know exactly when that occurred. It could have occurred a month ago, or some of it could have occurred 2 weeks ago. All it is telling you is sometime within the last 2 months, you've had elevated blood glucose levels. So it's a measure of some long-term elevated blood glucose levels, or it is indicative of. And typically the cutoff value for diagnosing whether they have diabetes or not with this HbA1c is 6.25%. So if you're 6.25 or less, then it is considered to be normal, and anything above that is considered to be a diabetes. So they have these different studies have these different target values as to where you want this number to be. But normally 6.25 is considered as not having diabetes randomly if you measure somebody. And this chart actually shows you how this HbA1c levels compare with the mean blood glucose levels. Okay. And but there are studies which keep moving these numbers around, but lower the better. Okay. I've seen numbers at one point were 7, and then they have reduced it further to this number to say this is the normal value. But for the sake of this course, 6.25, let's consider is normal. And that's the target that they try when the endocrinologists, when they're treating diabetes. Okay, so as I mentioned, type 1 diabetes was previously called juvenile onset, and as I mentioned, we're slowly moving away from the term because it can also occur in later ages. Although most commonly it develops during childhood or before the age of 30 if it happens in adults. And this is typically an autoimmune disease where the beta cells in the islets of Langerhans are destroyed by the body's own immune mechanism. And the onset is usually abrupt, but the immune attack starts much earlier, even before you can actually start seeing some of the signs and symptoms. And the immune attack is because the fundamental defect is loss of the self-tolerance by T cells. T cells recognize these beta cells as, or not specifically, the beta cells as being abnormal. And some of the proteins from the injured beta cells serve as antigens, and they're attacked by these antibodies and they're destroyed. So the destruction of the beta cells can start years before you can actually start seeing the symptoms of diabetes. Yeah.
Are they injured, the beta cells are injured by, or like, are they normally injured in most people and that's when they're attacked? Or are they injured by your immune system and then?
They're injured by the immune system and the proteins are released, and that gets,
Oh, okay.
so
And then
it
they get,
just,
like,
it's a
like,
vicious cycle. It's on and on. So I said autoimmune process may start well before the disease is evident clinically. So there's progressive loss of beta cells. Ultimately, at some point, loss of a few cells is not going to alter the insulin secretion that much, overall secretion that much, but when you start losing a significant number of beta cells, your insulin levels start to drop. And these patients, when tested, they show autoantibodies to the beta cells. And symptoms, to see symptoms, you need to lose a significant amount, okay? 90% of the beta cells you have to destroy before you start seeing very obvious symptoms. Well, as I mentioned, primary diabetes mellitus, there is also genetic susceptibility, but I'm not going through the slide. We're not going through the details of which gene and inheritance patterns. But just remember that there are multiple loci, okay, involved, and it's just not defects at one particular place. There seems to be a relation to type 1 diabetes and viral infections, specifically infections like mumps, rubella, the Coxsackie virus, cytomegalovirus, and so the relationship has been observed between viral infections and type 1 diabetes, and the possible mechanisms is the infection could probably affect the beta cells, and the infection then releases different types of proteins, okay, which then serve as the antigens for the immune system to attack. Or in certain cases, the viruses that are infecting, they can mimic the antigens in the beta cells, and so the antibodies start to attack, and the beta cells are destroyed in the process. And in certain cases, you might have an initial episode of the infection, then later it reemerges at a different time point. So there is some correlation with these viral infections. So, but these individuals may also be predisposed, okay, to this autoimmune reaction. Okay. The viral infections just seem to make it easier for the autoantibodies to attack. So the clinical course, of course, when you lose the beta cells, there is reduced insulin secretion, and we've seen that for the most part, glucagon, its physiological effects oppose the effects of insulin. So once you have loss of insulin, the effects of glucagon goes unopposed, and the effects on the glucose metabolism is the glucose is not stored in the form of glycogen. The glucose that you the glucose is not moved from the blood and stored in the form of glycogen. Once it's not moved, it's not stored, or if it is moved, the enzymes are not sufficiently activated to convert it to glycogen. On the other hand, the enzymes that normally inhibit the breakdown of glycogen, the enzymes that promote the breakdown of glycogen, insulin has an effect of inhibiting those enzymes, and lack of that effect means even some of the stored glycogen ends up being broken down. And we've seen that the other functions of insulin is to promote the storage of fats and proteins. They're not stored, and in fact the catabolic process of lipids and proteins are promoted, and basically you lose all kinds of fats, proteins, and carbohydrates. And so, along with hyperglycemia, you may also see elevated levels of proteins and lipids in the blood. Yeah.
The catabolic proteins and fats, is that because you're not storing glycogens, or is it because it's causing it?
If you remember, insulin actually promotes, once it moves the fatty acids into the adipose tissue, and it converts, where it's converted into triglycerides, and it's stored as triglycerides. So if you don't have this effect of insulin, then for example, the fatty acids in the blood would be diverted into the liver, and in the liver they would be degraded. Okay? And similarly in the proteins, normally insulin promotes the movement of proteins into muscles, and in insulin also in the muscles has an effect of protein. Promotes protein synthesis, but it inhibits protein breakdown. So all those effects are that. So it's unopposed. Okay. The action of glucagon is unopposed.
There's catabolism on proteins and fats, but you get increased proteins.
In the blood.
Okay.
Well, the couple of things going on. Within the cells, whatever protein is there, it's broken down. But insulin is also promoting the movement of protein into the muscles. So the protein can't get in, it can't be broken down. Okay. But what is in the cells are starting to be broken down. So hyperglycemia, once you have hyperglycemia, the amount of glucose that is filtered in the glomerulus also increases. In a normal individual, most of the glucose that is filtered in the glomerulus, almost 100% of the filtered glucose is reabsorbed by the body. So there is hardly any glucose excreted in the urine, okay, for somebody who's in glucose balance. However, in the case of hyperglycemia, you have elevated levels of glucose, so more than normal glucose is filtered, and the amount that is filtered exceeds the amount that is reabsorbed. Okay? Usually there's a balance between filtration and reabsorption, but the reabsorption can't keep up with the amount that is being filtered. So you end up with excretion of glucose in the urine that is referred to as glycosuria. Also, when you have more than normal amount of glucose that is filtered and more than normal amount of glucose moving to the renal tubule, that increases the osmolarity of the contents of the renal tubule. So that is going to pull more water from the body into the renal tubule at different levels, and these individuals are going to urinate large volumes, okay, of fluid, and so there is glycosuria and polyuria. Glycosuria is sugar in the urine, polyuria is increased volume of urine. The urine tastes sweet. Okay? In fact, that's how diabetes mellitus mentioned to you. Diabetes meaning, it's a Greek word meaning siphoning. It's siphoning out water. Mellitus meaning it has taste, which is sweetness here. That's opposed to diabetes insipidus, okay, which is large volume siphon, but it's tasteless. You don't have sugar. And I've all seen in movies, there's an old medical school joke. In the lab, when they're doing this test, the professor dips his finger in the urine, tastes it, and see it's sweet, and all the students think they got to do that as part of laboratory exercise, and then the professor says, well, I dipped this finger in, and I licked this other finger, and all you guys suckers, you licked the finger that you dipped in. Okay, so the urine tastes sweet. Does Dr. Beaton ever pull that trick on you guys in the lab? No? Okay. So there is excessive glucose in the urine, and there is polyuria. And once you have polyuria, that means you have less of water in the body, right? So once you have less water in the body, that could lead to other complications, like, which is not here, hypotension. The system blood pressure drops. That could be a complication. Note that down, it's not here. And once you lose a lot of water, the osmoreceptors, okay, in your, okay, the battery's down. So So in your hypothalamus, you have the osmoreceptors that's detecting osmolarity. So when you lose water, your blood and body fluid osmolarity increases. That triggers these thirst centers in the brain. And so these individuals are very thirsty. Okay? So the increased thirst, intense thirst, is referred to as polydipsia. So lack of insulin causes catabolism of proteins, fats, negative energy balance. Okay? So we've already gone through how it breaks down the glycogen in the body, it breaks down the protein, it breaks down the lipid. Although the blood levels increase, not enough is getting to the tissue. So these individuals are hungry. Okay? And also remember, insulin stimulates the satiety center in the brain normally. So lack of insulin, you're feeling more hungry than a normal individual. So that condition is called polyphagia, okay? Increased hunger. So polyuria, polydipsia, and polyphagia are the three classic P's associated with the polyuria is the true P. Okay. So polyuria, polydipsia, and polyphagia, and this is all related to glycosuria. And the weight loss and muscle weakness is paradoxical because they are very hungry. The paradox here is these individuals are very hungry, they're eating a lot, but all that food is not getting to where it's supposed to go. So they eat a lot, but still they have weight loss and muscle weakness. Okay. That's the paradox. Okay, and the lipid metabolism. So there is breakdown. Normally insulin promotes the storage of lipids and prevents lipolysis. So now the storage of lipids is not promoted and the lipids stored are broken down. And we've seen that the breakdown of these triglycerides lead to fatty acids, and in the liver the fatty acids are converted to coenzyme acetyl-CoA, and oxidation of acetyl-CoA produces these ketone bodies, okay, or ketoacids, the acetoacetic acid and beta-hydrobutyric acid, which is then secreted into the blood, and the increased ketone bodies or ketoacids in the blood is referred to as ketonemia or ketonuria. Essentially, it's contributing to the blood becoming more acidic. Okay? Remember, the worst combination is dehydration and and ketonemia. Okay? So ketonemia or ketonuria simply refers to the fact that the ketone body levels increase in the blood. So this is happening in parallel with dehydration. So there's nothing to dilute the pH. There's less of everything to dilute the increased hydrogen ion concentration. Consequently, the pH of the blood becomes very acidic. And it's these ketone bodies is what leads to this fruity odor in some of the diabetics with poor control of the blood sugar. And it's associated with a lot of other symptoms: nausea, vomiting, abdominal pain, confusion, lethargy. Basically, blood becoming acidic means essentially your brain and everything else is going to stop functioning. So coma and death in extreme cases. So, mentioned before, type 2 diabetes. We moved from type 1 to type 2 now. Previously called adult onset, but now you're starting to see it more and more in children too, with increase in childhood obesity. Okay? So we've known for a long time that there was some link between type 2 diabetes and obesity, but just over the last decade or so, we are starting to understand how exactly obesity is related to type 2 diabetes. Okay? And type 2 diabetes, there are multiple factors that contribute to it: environment, diet, sedentary lifestyles, and genetic factors could play some role in some individuals. Okay? These insulin receptors are naturally insensitive in some inherited conditions. And when it is inherited, there are multiple genes. Okay? But one thing type 2 diabetes is it's not an autoimmune disease. Okay? Insulin production is normal. The beta cells have the ability to produce insulin. Yes?
If you're predisposed genetically to get type 1, you develop type 2 or vice versa?
If you are predisposed to type 1, you could. If for some reason if these individuals are highly obese,
Let's say like without the obesity, you just have like a genetic factor or environmental factor, could it go back to the
between type 1 and type 2, I mean, in theory, yes. But how common it is, I have no idea. But generally, obesity and type 1, they don't go together because automatically things break down. But if it's genetic, if those insulin receptors are insensitive, so I would guess those cases are less common. Probably an endocrinologist would have the best answer.
Also, with type 2, it's not always obesity, right?
For most of the time, it's obesity.
Because I've met people who are type 2 diabetic but not obese at all.
No, that's what we're saying. There could be other things interfering with the insulin receptors not functioning. Okay, so you could have some secondary diabetes. We've talked about how
Oh, I see.
other hormonal defects could lead to. They could actually make the insulin receptors insensitive. For example, defects of growth hormone, defects of cortisol, excessive levels of those could. Okay.
In those cases, would the person get the diabetes way early on in life?
It depends when that secondary, it's due to some other cause. It depends on when that cause manifests, okay? And it's quite often possible that if those individuals, if the workout is not complete, they could be misdiagnosed as a classic type 2, but they may not be obese. So the key is finding out what the cause is. Okay, so the main finding here in type 2 diabetes is increased resistance of the peripheral tissue to insulin, and there is inadequate insulin secretion, and there's insulin insensitivity is correlated with obesity, and now we're starting to learn what the exact connection is between obesity and the insensitivity. This figure here, this cartoon here just shows you that in type 1 diabetes on top, the first one on top is normal. The red beads indicate insulin, and these tiny little things are on the membrane of the cells of the insulin receptors. They're normal, so these big arrows indicate that you have movement of glucose into the cell. Quite a large amount of glucose is moved into the cell. And the middle panel here shows type 1 diabetes, where you have the receptors on the membrane, but you have reduced insulin, reduced number of these red beads. Consequently, there is less glucose moving into the cells, less than normal. And the third scenario here excuse me, shows type 2 diabetes, where you have a lot of insulin, okay? In fact, more than normal insulin, but you have fewer receptors, and so there is only a little bit of glucose moving in. Okay. Okay. So still some of the links between, as I said, we're just starting to learn more and more about the link between obesity and type 2 diabetes. I'm just listing this as the hypothetical chain of events because We have some evidence that each of these steps are involved, but putting them all together and connecting them is it's not done yet. The details have not been worked out completely. So obesity, in obese individuals, that there is, from the adipose tissue, you have secretion of a lot of inflammatory mediators. Okay, and especially there are different inflammatory mediators, and in addition, there are these kinins known as adipokines. Okay, there are different types of adipokines. Some adipokines increase in number, other adipokines decrease in number, and but for the most part, the net effect of this adipokine secretion is that these adipokines generally make those receptors insensitive to insulin. So obese individuals, the adipose tissue releases inflammatory mediators and adipokines, and mainly these adipokines are responsible for making those insulin receptors insensitive. So target tissue develops insulin resistance, and initially, the initial reaction is when the target tissues become resistant to insulin, the system tries to overpower these receptors by increasing the amount. The pancreas tries to overpower these receptors by increasing the amount of insulin they secrete. But eventually, that elevated level of insulin does not have much of an effect. So by some type of a feedback mechanism, the beta cells over time reduce their insulin secretion. So it might be some type of a feedback mechanism. Okay? That they're sensing that the elevated insulin is not working, or they're being depleted, they're working hard. For whatever reason, their insulin secretion reduces later over time. But it doesn't mean they can't produce insulin. They still maintain the ability to produce insulin, but they just not produce it. That's why in these individuals, if you give those drugs like tolbutamide, you can stimulate the beta cells to produce insulin as they are undergoing weight loss and diet control. And there might be associated genetic defects. Coming to your point, you were asking a question about how could they have a genetic defect associated. It could be that individuals with type 2 may have a genetic defect leading to failure of beta cells in the long run. Yeah.
You don't mean failure like death, you just mean like decreased function, right?
Oh, no, not dying, not
You
dying.
still trigger them to work
Right,
with the drugs.
right.
Okay.
They're not synthesizing sufficiently. The cells are still there. Okay, and generally these individuals tend to be older, but as I said, now we're seeing it more and more in children too. They're over 40 years, they're obese. These are all statistics from epidemiological studies. In many cases early on, they're asymptomatic, okay, for the most part. And the first time you might ever see signs of diabetes in some of these type 2 diabetic patients is when you look into the eye. And then you, as optometrists, you actually start seeing changes in their retina. Okay. And metabolic ketoacidosis is rare because they always have some amount of insulin. Initially they have some, all I'm saying is the effects are not as bad as type 1 diabetes in these individuals. Most of the physiological effects is not as bad, as severe as in type 1. And so the condition has to be very severe in type 2 to see metabolic ketoacidosis. There is increased insulin, increased glucose, but however, most functions are not. Insulin still has some effect. Okay, it's just they're less sensitive, they're less effective. So the severity of the symptoms, it's going to take much longer to see the symptoms in these type 2 diabetes than in type 1. because in one case you don't produce, you're completely depleted of insulin. In the other case, the receptors are just not functioning as normally. Okay, gestational diabetes. As I mentioned, this is the diabetes that develops in pregnant women. Not all, but some, and in who actually gain a lot of weight. And some of them may actually be not just the gaining weight, because if just gaining weight pushes them in the direction of diabetes, then most pregnant women gain weight. So not everybody ends up with diabetes. So they have some predisposing factors also. Okay. For example, some of these women have increased glucose intolerance. Okay, to begin with, they're not strictly diabetics initially, but then it starts to manifest at the time of pregnancy when all of a sudden they gain a lot of weight. Going back to your question earlier, does the hyperglycemia, does it affect the fetus? Yeah, in many cases it actually does. There is increased birth weight. Often, in fact, the birth weight can actually double. What the normal birth weight is around 6 to 7 pounds, and some of these kids that have been affected by the gestational diabetes of the moms could, their birth weight could be double. They could be as much as 30 to 40 pounds, which is a big baby. So increased birth weight, and so consequently, many of these moms have to go for a C-section delivery, and these babies have a lot of other defects like increased respiratory distress syndrome. They themselves have an increased tendency for obesity and increased congenital birth defects like septal defects, heart septal defects, and so forth. Okay. And also these women who have gestational diabetes also have a tendency to develop type 2 diabetes later. I mean, many of them to begin with could be overweight, and but they haven't manifested the type 2 diabetes, but during pregnancy, when they put on additional weight, it triggers it. And so they generally tend to have abnormal glucose tolerance tests, but may have normal fasting glucose, and others have both abnormal oral glucose tolerance as well as fasting glucose tolerance. So things are not always normal in these women who develop gestational diabetes. There are always some signs that there is some level of hyperglycemia, but it's never there all the time. Okay, some of the complications, complications we would see in the later slides, but the pathogenesis, the causes for those complications. Glucose and other compounds related to glucose could form compounds with proteins in the cells, including blood vessels, both intracellular and extracellular proteins in different cells. These could be like the endothelial cells in the renal tubules. There's endothelial cells in the blood vessels. Essentially, the glucose could form complexes with those proteins within the endothelial cells, within the glomerulus, or within the blood vessels in general. And these complexes are referred to as the advanced glycation products. The advanced glycation products are nothing but complexes between glucose or glucose-related compounds and different proteins in the cell. And these, so this, the age, these complexes, they can then bind to receptors on inflammatory cells, okay? And the complex between age, or the advanced glycation end products, and inflammatory cells is referred to as RAGE, okay? So the age-RAGE complex. So this age-RAGE complex is what ultimately leads to most tissue damages, okay, especially in the blood vessels. So the advanced glycation end products, which are glucose and glucose compounds binding to proteins in the cell, mainly the endothelial cells in different tissues, and this complex then combines with inflammatory cells to form other complex, and it leads to an increase in these pro-inflammatory molecules like cytokines, which essentially contributes to increase in the thickness of the blood vessel walls. Okay? And this age-RAGE also leads to increase in reactive oxygen species within these cells. It leads to increase in the proliferation of fibroblasts, smooth muscle cells. Remember, you have smooth muscle cells around the arterioles, so not only is the basement membrane and the endothelial cells thickening, but, or I should say the basement membrane primarily thickens, but also the smooth muscles are thickening. Essentially, your blood vessel walls are getting very, very thick in these individuals, which means the lumens are getting smaller. That means the blood flow to the different tissues is going to be altered. So age directly cross-linked to extracellular matrix proteins, damage blood vessels by thickening and weakening walls. Okay? And increase atheroma. Atheroma is nothing but thickening of the blood vessel walls. That's the term, meaning thickening of the blood vessel walls, which could be due to many, many reasons. Okay? It could be due to increase in calcium, increase in cholesterol, increase in these inflammatory cells. So atheroma is a general term, thickening of blood vessels. Atherosclerosis, okay, on the other hand, is thickening of the blood vessels due to cholesterol and calcium primarily. So atheroma is a general term of thickening. So hyperglycemia is pro-inflammatory, so it stimulates an inflammatory response, and it activates protein kinase C, and it's the protein kinase C which later brings about these inflammatory effects. So hyperglycemia can activate protein kinase C, and protein kinase C, the downstream effect is activation of inflammation. Just in this context, I'm mentioning Roboxystorin. This is the brand name of a drug from Lilly, and this drug, I don't know which stage of the trial this is in, for diabetic peripheral retinopathy. Okay? The blood vessel changes you see in the retina in diabetic retinopathy, the peripheral blood vessels. It's being tested to determine if it can actually reduce these inflammatory effects in the blood vessels, the peripheral retina. The mechanism of action of this drug is by inhibiting protein kinase C. Consequently, the downstream inflammation is also suppressed. And hyperglycemia leads to the release of many cytokines, and it also leads to vascular endothelial growth factors, which in turn normally promotes the formation of new blood vessels. In the earlier slide, I mentioned that hyperglycemia leads to the increase in reactive oxygen species. But normally the body has multiple mechanisms to quench these reactive oxygen species. But hyperglycemia, in addition, what it does is it also tends to reduce the body's response to oxidative stress. It's increasing the reactive oxygen species, and at the same time, it also has a tendency to reduce the body's mechanism to deal with increased reactive oxygen species, and that leads to many complications. For example, there are some tissues in the body that really don't have insulin receptors. So some amount of glucose is getting in, but a typical example is the lens inside your eye. The lens does not have glucose. The lens epithelium does not have glucose, insulin receptors, but glucose can get it. Okay, but in diabetic patients, since there is more glucose available in the blood, you could have more than normal glucose getting into those tissues, because glucose gets in without the help of insulin, those tissues normally. But when more glucose is available in the blood, more glucose is getting into these tissues like the lens, which normally don't need insulin. Normally, in these tissues, the glucose is metabolized to this substance called sorbitol using NADPH. NADPH is one of the mechanisms for counteracting these reactive oxygen species, dealing with oxidative stress. But in diabetes, what happens? You have more than normal glucose getting into the lens, so more of that glucose is converted to sorbitol, so a lot more NADPH is being used. So some of the normal action of NADPH is to counteract the reactive oxygen species. So the reactive oxygen species start building up in the lens. Okay? And so sorbitol builds up, and there is less NADPH, so the lens's response to oxidative stress is impaired, and that's a perfect storm for the lens to change its refractive index and for the patient to develop cataract. We'll come back to this again. Okay, and then there are changes with blood vessels, microangiopathies, and in the blood vessels you have increase in the thickening of the basement membrane, especially in the arterioles, capillaries, and so the basement membrane thickens, so the blood vessel wall thickens, the lumen gets smaller, so there is less blood being delivered to the tissue. At the same time, the capillaries become very leaky. The endothelial cell junctions are also affected, the tight junctions. So they're not only does the blood vessel walls become thicker, but they're carrying less blood, but these vessels are also getting very leaky. And then the renal glomerulus and the renal tubules and nerves, they're all affected too. Basically thickening up of the glomerulus, which is actually a capillary bed, but the renal tubules, and they're also thickening. Forget the term nerves. Yeah.
Wait, what, again, one second.
What? Just drop the term nerves here. Yeah. It'll take us off on a tangent. So atherosclerosis is accelerated, okay, in these individuals. So there might be individuals who are predisposed to atherosclerosis, but it just happens earlier in individuals with diabetes. Okay, the thickening. Already the plaque is building up, say, in these individuals and making the blood vessel walls thicker, but now the effect of diabetes mellitus causes further thickening of the basement membrane, so the effects of atherosclerosis are now, the manifestations are much earlier. Okay. And this is just a statistic, the myocardial infarctions and cerebral infarctions. These are main causes of death in diabetes mellitus. Uh, Normally, myocardial infarctions, they have more common in males than females for individuals before the age of 45. But when the males and females tend to have diabetes, the prevalence of the myocardial infarctions become equal in the two. Okay. Females have some protective effects because of their hormones. Okay. Females who produce estrogen. Okay. So they have some protective effect against myocardial infarctions. But when the individual has diabetes, whatever advantage is provided by the estrogen is counteracted considerably, so the males and females have equal prevalence of myocardial infarction when they have diabetes for the ones under the age of 45.
What's the CI again?
Cerebral infarctions,
What's that?
CI,
What is that?
or myocardial, I'm sorry, coronary infarctions. Let's see. And then you have changes with the arterioles also. The arteriolar atherosclerosis generally deals with the larger arteries, and you have similar changes with the arterioles also. And as with other places, these vessels are leaky. And these arteriosclerosis, thickening of the basement membrane of the arterioles and the leaky vessels, occur everywhere in the body, and you could see it in the kidney, you could see it in the retina. And these individuals with atherosclerosis and arteriolosclerosis are all more prone to gangrene. This is because there is less blood flow. Okay, so initially, say there is an infection, and then the infection takes longer to heal. But then you have reduced blood flow to the extremities and different parts of the body because your arteries and arterioles have thickened and the lumen has gotten smaller. Once you have less blood, that means there is less oxygen to these infected areas. And then agents like Clostridium, these anaerobic agents, can actually infect these, and then ultimately it leads to the degeneration of these extremities. Essentially, once you have lack of blood flow and oxygen, that could lead to the development of other microbial organisms that grow which don't need oxygen, okay, like Clostridium, for example, and that leads to gangrene. So the only recourse is those body parts have to be amputated. Okay, as far as your retina, the blood vessel vascular changes in your retina, it could be the earliest presentations in the retina are referred to as early background retinopathy. This manifests as microaneurysms in the blood vessels. Microaneurysms are nothing but outpouchings of the blood vessels. So these are tiny little outpouchings of blood vessels. And in addition to these microaneurysms, these individuals also present with hemorrhages. The hemorrhages could be of different types. They look like a tiny dot, known as dot hemorrhages, or it could look like a little blot, ink blotting, known as blot hemorrhages, or it could be more flame-shaped. Okay, you could have dot, blot, or flame-shaped hemorrhages. And in addition, you could also have exudates. Okay, these exudates, which are shown here, these yellowish regions or whitish yellowish regions, these are nothing but lipids. Once you have blood and other material, serum and things leaking out of the blood vessels, over time the fluid is all reabsorbed, and all you're left with from the leak is the lipids, which are not reabsorbed. And these lipids are the ones that present as exudates. Okay. So initially you have microaneurysms, and then from leakage or the breakage of these aneurysms, you have hemorrhages, and later, hemorrhages, the blood is spilling there, then you have reabsorption of most of the spillage except for the lipids, and those lipids remain as exudates. And this is not in the severe form of diabetic retinopathy. Okay, and this slide is just showing you these microaneurysms, hemorrhages, and exudates in a, this is in a normal fundus appearance. This is with fluorescein angiography, where these microaneurysms, a lot more of them, which normally you can't see in a regular fundus examination, are revealed. These numerous white dots, these microaneurysms are all revealed by fluorescein angiography. And here, this is just showing in retinas that were extracted from the eyes of diabetic patients and a normal person. These are trypsin digested retinas, and this is how the normal retinal blood vessels ought to appear. And these are the trypsin digested retinas from an individual with diabetes. You can see all these microaneurysms, these outpouchings of the blood vessels. Okay, another complication of diabetes, as far as the retina is concerned, is maculopathy. What we talked about so far was background, early background diabetic retinopathy. In maculopathy, it means that the macula is involved, and you could have fluid leaking, okay, in the macular region, and or you could have hemorrhages in that region. But most of the fluid that leaks over time could be absorbed. Now there are treatments for reducing the edema in the macular region, but something that does not get reabsorbed are the lipids. Okay, so the lipids will stay as these exudates.
The fluid can be reabsorbed only with treatment, or
Some of it occurs naturally, but now there are drugs that can. Well, common as Dimox. You give Dimox, you give to reduce macular edema. And but the hard exudates. Of course, when the macular edema is there, the patient knows. I mean, he or she is going to come to you because their vision is going to be impaired. But with the background diabetic retinopathy, they may not notice that their vision's reduced because it's more in the periphery. The macula is bad in those cases. Okay, the more complicated form of diabetic retinopathy is the proliferative diabetic retinopathy, and in this case, you have complications from the hypoxia that results. Now your blood vessel, the lumen's getting narrow, and so there is less blood flow, there is hypoxia. This causes beating of the blood vessels and kinks forming in these blood vessels, which you could see just from a regular fundus examination. And as a result of hypoxia, and also remember you have VEGF being secreted, you could have neovascular growth, okay, and these are all new blood vessels, and then there is fibrous tissue growth, there is inflammatory response, there are fibroblasts, and then you're going to have everything, when the fibrous tissue forms, things contract. And that contraction could lead to other complications if those newly formed blood vessels are in your vitreous. So these blood vessels, the newly growing blood vessels, can grow not just on your retina, but they could grow into the vitreous. Okay? And when these blood vessels break, rupture, you could have vitreal hemorrhage, which is pre-retinal hemorrhage. And you could also have new blood vessels forming around your nerve head. Whenever new blood vessels are being formed, they can zap these blood vessels by using laser, doing a pan-retinal photocoagulation. But when these new vessels are forming closer to the fovea, it's more difficult to zap them. And also when you have neovascularization in the optic nerve head, surgeons are more hesitant to go in there with the laser because you might injure neurons too. Yeah. another 5 or 6 slides.
Okay.
Yeah.
I just want to make sure everything's there. Sorry.
Well, but I'm recording. I made
Okay.
sure that I'm recording this half.
Awesome.
Yeah. So the neovascularization of the optic nerve head, it's more difficult to control because they hesitate lasering those regions. Okay, and as I mentioned, you have scar tissue formation, okay, because there is fibroblast proliferation, and there is scar tissue formation. And especially if the scar tissue formation occurs in the vitreous, that is going to pull the retina towards the vitreous, and that would lead to retinal detachment. And all of these diabetic conditions, diabetic retinopathy conditions, are highly correlated with kidney disease.
Do you have any idea why?
Any idea why? Because at the same time there are changes going on in the kidney also, because as you would see, it affects, we have a few more slides there which shows what's going on in the kidney. As I said, when you have elevated blood glucose levels, it's affecting multiple tissues in the body, okay? The retinas. Essentially, when you reach those levels, that means it's more advanced. Proliferative diabetic retinopathy is a more advanced stage of retinopathy than background diabetic retinopathy. So when you get to those levels, probably your other organs are affected too, to a greater amount. And one of the long-term complications of diabetes mellitus is growth of new blood vessels on the iris, and that is known as rubiosis iridis. When you have blood vessels growing in the iris, some of those vessels can actually grow also in the angle of the anterior chamber, and that would then obstruct the drainage of the aqueous, and these individuals can end up with secondary glaucoma. But these are in very, very advanced stages, so they have to be very poorly controlled. And you wouldn't see those cases commonly in our practices, unless you work in a VA hospital or someplace. Okay, another complication, as I mentioned, is cataract. Cataract can change the change in the refractive index of the lens that results from increased blood glucose can lead to myopic shifts. So, as I mentioned, there are no insulin receptors on the lens epithelium. So normally, some glucose gets in by itself, and but that glucose is normally converted to sorbitol by combining with NADPH. But in individuals with diabetes, you have more than normal glucose going in, so more of the NADPH is used up. You have increased amount of sorbitol, and sorbitol then gets converted to fructose, so the sugar actually builds up in the lens. Initially, these changes, when they occur initially, it changes the refractive index of the lens, and that change in the refractive index is what is causing this myopic shift. But then when they control the blood sugar, the refractive index could go back to normal. But in cases where it is uncontrolled, there is excessive fructose formation, and that could then lead to what are known as sugar cataracts. So in the early stages, it could be a transient effect, as I said, causing a myopic shift. But when you have excessive buildup of fructose, it leads to a cataract in these diabetic patients, which is referred to as sugar cataracts. Okay, and there are changes occurring, long-term complications in the pancreas. Of course, this is the reason was you were losing these beta cells. You have decrease in size of the number of islets. They are infiltrated by lymphocytes, and that's in type 1 diabetes. In type 2 diabetes, There could be reduction in the number of islets, but that's not the primary reason. But there seems to be some correlation with the development of these myeloid deposits in these type 2 diabetic patients. The kidney is affected. That's because, as with other blood vessels, the glomerulus is affected. Just like in the other blood vessels, you have thickening of the basement membrane in the glomerulus. And once the arterial or the capillary wall thickens, the glomerulus is sclerosed, and the sclerosis of the glomerulus could be very diffuse. There is diffuse thickening that is spread out, or the thickening of the blood vessels could be concentrated in certain regions that appears as nodules. So there is diffuse glomerulosclerosis or nodular glomerulosclerosis. Sclerosis is just thickening of the blood vessels, okay? Blood vessel wall. So the blood flow reduces and the vessels tend to appear more transparent or white. Okay, that's sclerosis. So it could be diffuse, or it could be have the appearance of nodules. And this happens, and of course then once your glomerulus gets thick, there is reduced blood flow, filtration is affected, and once your kidney is not filtering, there's loss of function. These individuals would then need other types of treatments. So you could have lesions with the glomerulus, or you could have lesions with the other blood vessels that are supplying the tissues of the kidney. Okay. So the glomerulus is just that part of the blood vessels which is involved with filtration, but you have other blood vessels supplying to these other tissue components of the kidney, and once they don't get sufficient blood flow, basically they can develop lesions, and reduced blood flow means they can, when you have kidney infections, you're not able to fight those infections, and ultimately they could have inflammation and renal failure. And then these individuals have to go for either, most of the time they go for dialysis in order to filter. And the nervous system is affected, the central as well as the peripheral nervous system. The example of central nervous system was your retina. And you have peripheral neuropathy, which is very common. Again, this mainly results from reduced blood flow. Okay? There is ischemia, and the function of the peripheral nerves deteriorate over time, and you have demyelination that could result from this. And finally, the distal sensory as well as the motor nerves are affected. Okay? And once the distal sensory nerves are affected, there is loss of sensation. When there is loss of sensation, there is increased infection. And the autonomic nervous system is also affected. The autonomic nerves are affected. They degenerate over time, show degenerative changes. Consequently, there are GI tract disorders because the GI tract activity is all controlled by the autonomic nervous system. And the bladder function is affected. There is sexual dysfunction. And all of this is stemming from reduced blood flow, ultimately, to all of these organs. And the reduced blood flow leads to deterioration of the kidney, deterioration of the nerves, and leads to all kinds of complications.